Hi everyone, welcome to Pharmacology. So today we are going to discuss about anti-cancer drugs. So this chapter is little bit lengthy, so I will take it as two parts. And regarding this anti-cancer drugs, the most important thing is the classification. The classification is very important, and also the specific toxicities associated with the anti-cancer drugs. So let's begin this chapter. So cancer is a large group of diseases that can start in almost any organ or tissue of the body when abnormal cells grow uncontrollably, go beyond their usual boundaries to invade adjoining parts of the body and or spread to other organs. So this spreading to other organs, the process is called as metastasis, and it is a major cause of death from cancer. And this cancer is a kind of genetic disorder. It happens when genes that manage cell activity mutate and create abnormal cells that divide and multiply, eventually disrupting how your body normally works. A neoplasm and malignant tumor are other common names for cancer. So other names for cancer is neoplasm as well as tumor. Lung, prostate, colorectal, stomach and liver cancer are the most common types of cancer in men, while breast, colorectal, lung, cervical and thyroid cancer are the most common among women. Principles of cancer chemotherapy. Cancer chemotherapy strives to cause a lethal cytotoxic event or apoptosis in the cancer cells that can arrest the progression of tumor growth. So as I have already mentioned, cancer means abnormal cell growth. Okay, so the cancer chemotherapy, the purpose is to cause a lethal cytotoxic event or apoptosis in the cancer cells. Thereby, that can arrest the progression of the tumor growth or the abnormal cell growth. The attack is generally directed toward DNA or against metabolic sites essential to cell replication. For example, the availability of purines and pyrimidines. These purines and pyrimidines are the building blocks for DNA or RNA synthesis. Ideally, anti-cancer drugs should interfere only with cellular processes that are unique to malignant cells. Unfortunately, most traditional anti-cancer drugs do not specifically recognize neoplastic cells but rather affect all kinds of proliferating cells, both normal and abnormal. So this is one of the most important problem associated with the anti-cancer drugs, that is, these drugs do not specifically recognize neoplastic cells but they affect all kinds of proliferating cells, both normal as well as abnormal cells. Therefore, almost all anti-tumor agents have a steep dose response curve for both therapeutic and toxic effects. Before going deep into the anti-cancer drugs, it is very mandatory to know the structure of DNA. Each strand of a DNA molecule is composed of a long chain of monomer nucleotides. The nucleotides of DNA consist of a deoxyribose sugar molecule to which is attached a phosphate group and one of four nitrogenous bases. And the four nitrogenous bases are two purines, which includes adenine and guanine, and two pyrimidines, which includes the cytosine and the thymine. Okay, so here you can see the structure of a nucleotide, which consists of a deoxyribose sugar molecule, a phosphate group and a nitrogenous base. Okay, four nitrogenous bases. The nucleotides are joined together by covalent bonds between the phosphate of one nucleotide and the sugar of the next, forming a phosphate sugar backbone from which the nitrogenous bases protrude. And one strand is held to another by hydrogen bonds between the bases. Okay, so the nucleotides are joined together by covalent bonds, whereas one strand is held to another by the hydrogen bonds. That is, in between the nitrogenous bases there is hydrogen bonds, and the sequencing of this bonding is specific. That is, this hydrogen bond sequencing is specific. That is, adenine bonds only with the thymine and cytosine only with the guanine. Now coming to the RNA. The RNA consists of ribose nucleotides. In DNA consists of deoxyribose sugar, whereas RNA consists of ribose sugar. Okay, ribose nucleotides. That is the nitrogenous bases appended to a ribose sugar, attached by a phosphodiester bonds forming strands of varying lengths. The nitrogenous bases in RNA are adenine, guanine, cytosine and uracil, which replaces thymine in DNA. In DNA, the four nitrogenous bases are adenine, guanine, cytosine and thymine. In RNA, instead of this thymine, that is, the thymine is replaced by uracil. So this is a main difference between DNA as well as RNA. Now the treatment strategies. Goals of treatment. The ultimate goal of chemotherapy is a cure, that is, long-term disease-free survival. A true cure requires the eradication of every neoplastic cell. If a cure is not attainable, then the goal becomes control of the disease. Control of the disease in the sense, prevent the cancer from enlarging and spreading, to extend survival and maintain quality of life of the patient. In all cases, the neoplastic cell burden is initially reduced or debulked either by surgery and or by radiation, followed by chemotherapy, immunotherapy, then therapy using biological modifiers or a combination of these treatment modalities. In advanced stages of cancer, the goal is palliation. Palliation means elevation or reduction of symptoms and avoidance of life-threatening toxicity. This means that chemotherapeutic drugs may be used to relieve symptoms caused by the cancer and improve the quality of life even though the drugs may not extend survival. What all are the indications for the chemotherapeutic treatment? Chemotherapy is sometimes used when neoplasms are disseminated. Disseminated means spread and are not amenable to surgery. Adjuvant chemotherapy. Adjuvant chemotherapy means chemotherapy may also be used as supplemental treatment to attack micrometastasis following surgery and radiation treatment, in which case it is called adjuvant chemotherapy. So adjuvant chemotherapy is a kind of supplemental treatment. Okay, it's a kind of supplemental treatment. Next is neoadjuvant chemotherapy. Here, chemotherapy given prior to the surgical procedure in an attempt to shrink the cancer. Okay, so this neoadjuvant chemotherapy is given prior to the surgical procedure. Then maintenance chemotherapy. Here, chemotherapy given in lower doses to assist in prolonging remission. Okay, it is for maintenance. Okay, maintenance chemotherapy. Next is about the tumor susceptibility and the growth cycle. The fraction of tumor cells that are in the replicative cycle, which is known as a growth fraction. This growth fraction influences the susceptibility to most cancer chemotherapeutic agents. Rapidly dividing cells are generally more sensitive to chemotherapy, whereas slowly proliferating cells are less sensitive to chemotherapy. So in general, we can say that non-dividing cells usually survive the toxic effects of many chemotherapeutic agents. So now the most important point is the cell cycle specificity of the drugs. Chemotherapeutic agents that are effective only against replicating cells. Replicating cells means those cells that are dividing are said to be cell cycle specific. So cell cycle specific means chemotherapeutic agents that are effective only against the replicating cells or dividing cells. Okay, such chemotherapeutic agents are known as cell cycle specific drugs, whereas other agents are cell cycle non-specific. Although the non-specific drugs generally have greater toxicity in cycling cells, they are also useful against tumors that have a low percentage of replicating cells. Now about the treatment regimens and scheduling. Drug dosages are usually calculated on the basis of the body surface area in an effort to tailor the dosage to each patient. So the first point is the log kill phenomenon. So log kill phenomenon means destruction of the cancer cells by chemotherapeutic agents follows first order kinetics. Okay, that is a given dose of the drug destroys a constant fraction of cells. The term log kill is used to describe this phenomenon. Next is about the pharmacologic sanctuaries. That is, the leukemic or other tumor cells find sanctuary in tissues such as the central nervous system, where transport constraints prevent certain chemotherapeutic agents from entrance. Therefore, a patient may require irradiation of the craniospinal axis or intrathecal administration of a drugs to eliminate leukemic cells at that site. Similarly, drugs may be unable to penetrate certain areas of solid tumors. Okay, so this is what is known as the pharmacologic sanctuaries. Treatment protocols. Combination chemotherapy is more successful than single drug treatment in most cancers for which chemotherapy is effective. So combination therapy is more successful compared to individual or single drug therapy. So combination chemotherapy. Cytotoxic agents with different toxicities and with different molecular sites and mechanisms of action are usually combined at full doses. So this results in higher response rates due to additive and or potentiated cytotoxic effects and non-overlapping host toxicities. In contrast, agents with similar dose-limiting toxicity such as myelosuppression, nephrotoxicity or cardiotoxicity can be combined safely only by reducing the doses of each. Then what all are the advantages of combination chemotherapy? This combination provides maximal cell killing within the range of tolerated toxicity. Then it is effective against a broader range of cell lines in the heterogeneous tumor population. And the third point is that it may delay or prevent the development of resistant cell lines. So many cancer treatment protocols have been developed and each is applicable to a particular neoplastic state. They are usually identified by an acronym. For example, a common regimen called RCHOP or RCHOP, it is used for the treatment of non-Hodgkin lymphoma. Consists of, that's RCHOP. The R is for rituximab and C stands for cyclophosphamide, H for hydroxydonorubicin. Hydroxydonorubicin is also known as doxorubicin. Then O stands for oncovin, which is a brand name for vincristine, and P for prednisone. Okay, so this is a common regimen for the treatment of non-Hodgkin lymphoma. Usually they are identified by an acronym RCHOP. Therapy is scheduled intermittently to allow recovery or rescue of the immune system, which is also affected by the chemotherapeutic agents, thus reducing the risk of serious infection. Resistance and toxicity with the chemotherapy. Cancer drugs are toxins that present a lethal threat to the cells. Cells have evolved elaborate defense mechanisms to protect themselves from chemical toxins, including the chemotherapeutic agents. So first such mechanism is resistance. Some neoplastic cells, for example melanoma, are inherently resistant to most anti-cancer drugs. Other tumor types may acquire resistance to the cytotoxic effects of a drug by mutating, particularly after prolonged administration of suboptimal doses. The development of drug resistance is minimized by short-term, intensive, intermittent therapy with a combination of drugs. Drug combinations are also effective against a broader range of resistant cells in the tumor population. Then multi-drug resistance. Stepwise selection of an amplified gene that codes for a transmembrane protein is responsible for multi-drug resistance. This resistance is due to adenosine triphosphate dependent pumping of drugs out of the cell in the presence of P-glycoprotein. Cross resistance following the use of structurally unrelated agents also occurs. For example, cells that are resistant to the cytotoxic effects of the Vinca alkaloids are also resistant to dactinomycin and to the anthracycline antibiotics, as well as to colchicine and vice versa. P-glycoprotein is normally expressed at low levels in most cell types, but higher levels are found in the kidney, liver, pancreas, small intestine, colon, and adrenal gland. So it has been suggested that the presence of P-glycoprotein may account for the intrinsic resistance to chemotherapy observed with adenocarcinomas. Certain drugs at high concentrations, for example verapamil, can inhibit the pump and thus interfere with the efflux of the anti-cancer agent. That is, the P-glycoprotein inhibitors can interfere with the efflux of the anti-cancer drugs. Toxicity. Therapy aimed at killing rapidly dividing cancer cells also affects normal cells undergoing rapid proliferation. For example, cells of the buccal mucosa, bone marrow, gastrointestinal mucosa, and hair follicles, contributing to the toxic manifestations of chemotherapy. Okay, so this is one of the most important disadvantages of chemotherapy. That is, along with the abnormal cells, these chemotherapeutic drugs also affects the normal cells undergoing rapid proliferation. So here you can see the common adverse effects. Cardiotoxicity associated with the doxorubicin, then bladder toxicity with the cyclophosphamide, then myelosuppression that predisposes to infection are common to many chemotherapeutic agents. Then most chemotherapeutic agents have a narrow therapeutic index. Severe vomiting, stomatitis, bone marrow suppression, and alopecia. Then vomiting is often controlled by administration of antiemetic drugs. So specific drugs we will discuss in detail in the coming slides. In the previous slide, we have seen the adverse effects associated with the chemotherapeutic agents. Now, how we will minimize these adverse effects? So the first point is use of cytoprotectant drugs. Next, local perfusion of the tumor. For example, a sarcoma of the arm. Then removal of some marrow of the patient prior to intensive treatment and then re-implantation afterwards. Then intensive hydration and diuresis to prevent bladder toxicities. Then the megaloblastic anemia that occurs with the methotrexate can be effectively counteracted by administering folinic acid. Folinic acid is also known as leucovorin. Then human granulocyte colony stimulating factor, which is also known as filgrastim. The neutropenia associated with the treatment of cancer by many drugs can be partially reversed with the help of this granulocyte colony stimulating factor. So these all are the points that can be used to minimize the adverse effects associated with the anti-cancer drugs. Now we will see the treatment induced tumors. Because most anti-neoplastic agents are mutagens. Neoplasms, for example, acute non-lymphocytic leukemia, may arise 10 or more years after the original cancer was cured. Okay, so from the name itself, it's clear that treatment-induced tumors, there are certain chemotherapeutic treatments that can induce tumors after certain years. Okay, these types of tumors may arise 10 or more years after the original cancer was cured. Treatment-induced neoplasms are especially a problem after therapy with the alkylating agents. Okay, so this is very, very important. Treatment-induced neoplasms are most commonly occur or especially a problem after therapy with the alkylating agents. Most tumors that develop from cancer chemotherapeutic agents respond well to treatment strategies. So in this slide, we will discuss about the cell cycle. So the cell cycle consists of mainly two phases. That is, first one is the interphase and second one is the M phase or mitosis phase. The interphase is a non-dividing phase. The interphase itself has three phases. First one is the G1 phase, that is the first growth phase, and the second one is the synthesis phase or S phase, and the third one is the second growth phase or G2 phase. So here you can see this is the interphase. Okay, this is the interphase, and the interphase consists of mainly three phases. First one is the G1 phase. Okay, G1 means first growth phase. Okay, in first growth what will happen? Normal cell growth and function, the role of the cell in an organism or as an organism is fulfilled in this phase. And the second one is the DNA synthesis phase or the S phase. Here the DNA is unwound and replicated in preparation for division. Okay, so in S phase DNA replication occurs. And the third one is the G2 phase or the second growth phase. Here cell growth in preparation for mitosis. Mass of the cell and number of organelles must almost double. Okay, and the second phase of cell cycle is the mitosis. And the mitosis consists of mainly four phases, that is prophase, metaphase, anaphase and a telophase. So we have learned about the cell cycle in the previous slide. Now we will see about the effects of chemotherapeutic agents on the growth cycle of mammalian cells. Okay, so this is the cell cycle again. G0 phase. G0 means it is a resting state, that the cell is not dividing, and this is the G1. G1 or the first growth phase. Here synthesis of enzymes needed for DNA synthesis occurs, and this is the S phase. S phase means here the DNA replication occurs, that is the DNA is replicated. Now G2 phase. G2 phase means synthesis of the cellular components required for mitosis, and next phase is the mitotic phase where the cell divides. Okay, and now cell cycle specific drugs. Okay, so here you can see the examples for anti-cancer drugs which are cell cycle specific. So examples including antimetabolites, bleomycin, etoposide and vinca alkaloids. So these cell cycle specific drugs are effective for high growth fraction malignancies such as hematologic cancers. Now cell cycle non-specific drugs. Examples include alkylating agents, antibiotics, cisplatin, nitrosourease. These drugs are effective for both low growth fraction malignancies such as solid tumors as well as high growth fraction malignancies. So far we have completed the introduction portion of anti-cancer drugs. Now we will discuss the classification of anti-cancer drugs one by one. So the first one is antimetabolites. Under antimetabolites, the first category is folate antagonist. Examples include methotrexate, pemetrexate, pralatrexate. And the second one is purine antagonist. Examples including 6-mercaptopurine, 6-thioguanine, azathioprine, fludarabine and cladribine. And the third one is pyrimidine antagonist. Examples including fluorouracil, capecitabine, floxuridine. And the fourth antimetabolite category is cytidine analogs. Examples include cytarabine, azacitidine and gemcitabine. So what these antimetabolites will do? These drugs will generally interfere with the availability of normal purine or pyrimidine nucleotide precursors either by inhibiting their synthesis or by competing with them in DNA or RNA synthesis. Their maximal cytotoxic effects are in the S phase. S phase means DNA replicating phase. Okay, and are therefore cell cycle specific. So this antimetabolites are cell cycle specific drugs and their maximal cytotoxic effects are in the S phase. S phase means DNA synthesis or DNA replicating phase. Examples we have already discussed, that is a methotrexate, pemetrexate and pralatrexate are folate antagonist. Okay, folate antagonist. The vitamin folic acid plays a central role in a variety of metabolic reactions involving the transfer of 1 carbon units and it is essential for cell replication. Folic acid is obtained mainly from dietary sources and from food sources produced by intestinal flora. So again, let's see them. Remember the names again. Antifolate agents are methotrexate, pemetrexate and pralatrexate. Then moving on to the mechanism of action of folate antagonist. Methotrexate is structurally related to folic acid and this methotrexate acts as an antagonist of the vitamin by inhibiting mammalian dihydrofolate reductase. Okay, and this dihydrofolate reductase enzyme is responsible for the conversion of folic acid to its active coenzyme form tetrahydrofolic acid. So the mechanism of action of this methotrexate or folate antagonist is that these drugs will inhibit the dihydrofolate reductase enzyme. Thereby, the folic acid cannot get converted into its active form, which is the tetrahydrofolic acid. The inhibition of dihydrofolate reductase can only be reversed by a 1000-fold excess of the natural substrate dihydrofolate or by administration of leucovorin, which bypasses the blocked enzyme and replenishes the folate pool. Leucovorin, or otherwise known as folinic acid, is the N5-formyl group carrying form of FH4. So, an antagonist for methotrexate toxicity is leucovorin or folinic acid. This methotrexate is specific for the S phase of the cell cycle. And here you can see the mechanism of action of methotrexate. Okay, so the methotrexate inhibits the dihydrofolate reductase enzyme and this dihydrofolate reductase is responsible for the conversion of folic acid to its active coenzyme form, which is the tetrahydrofolic acid. This pemetrexate is an antimetabolite similar in mechanism to methotrexate. However, in addition to inhibiting dihydrofolate reductase, it also inhibits the thymidylate synthase and other enzymes involved in folate metabolism and DNA synthesis. Pralatrexate is an antimetabolite that also inhibits dihydrofolate reductase. Therapeutic uses. This methotrexate, usually in combination with other drugs, is effective against acute lymphocytic leukemia, Burkitt lymphoma in children, breast cancer, bladder cancer, and head and neck carcinomas. Then low-dose methotrexate is effective as a single agent against certain inflammatory diseases such as severe psoriasis and rheumatoid arthritis as well as Crohn's disease. Then all patients receiving methotrexate require close monitoring for the possible toxic effects. Pemetrexate is primarily used in non-small cell lung cancer. Pralatrexate is used in relapsed or refractory T-cell lymphoma. Now moving on to the pharmacokinetics of folate antagonist. These drugs can be administered by oral, intramuscular, intravenous and intrathecal routes. Because methotrexate does not easily penetrate the blood-brain barrier, it can be administered intrathecally to destroy neoplastic cells that thrive in the sanctuary of the CNS. High concentrations of the drug are found in the intestinal epithelium, liver and kidney as well as in ascites and pleural effusions. Methotrexate is also distributed to the skin. Small amounts of methotrexate undergo hydroxylation at the 7th position to form 7-hydroxymethotrexate. This derivative is less water soluble than methotrexate and may lead to crystalluria. So the 7-hydroxymethotrexate is responsible for causing crystalluria. Therefore, it is important to keep the urine alkaline and the patient well hydrated to avoid renal toxicity. Excretion of the parent drug and the 7-hydroxymetabolite occurs primarily via the urine. It is used at an oral dose of 15 to 30 mg daily. This is a dosing of methotrexate. Okay, usually given at an oral dose of 15 to 30 mg daily and at a dose of 20 to 40 mg per meter square of the body surface area by intramuscular or intravenous injection in a twice a week schedule. High-dose methotrexate such as 1 to 5.5 gram per meter square is used for long infusion over a period of 24 hours in every 2 to 4 weeks duration. For cases of acute lymphoblastic leukemia, leucovorin rescue therapy within 24 hours of methotrexate infusion is started. Low doses such as 2.5 mg per kilogram for 5 days followed by 2 days rest or 10 to 25 mg by the intravenous route once weekly is given for severe psoriasis. Smaller doses are also used for the induction of remission in rheumatoid arthritis. So we have completed the folate antagonist under antimetabolites. So the next one is purine antagonist. So the first drug under purine antagonist is 6-mercaptopurine. So the 6-mercaptopurine is a purine antimetabolite. It is the thiol analog of hypoxanthine. The 6-mercaptopurine and 6-thioguanine were the first purine analogs to prove beneficial for treating neoplastic disease. Azathioprine, which is an immunosuppressant, exerts its cytotoxic effects after conversion to 6-mercaptopurine. Okay, so this is an important point. That is, azathioprine, it is an immunosuppressant. It exerts its cytotoxic effects after conversion to 6-mercaptopurine. The 6-mercaptopurine is used principally in the maintenance of remission in acute lymphoblastic leukemia. 6-mercaptopurine and its analog azathioprine are also beneficial in the treatment of Crohn's disease. Azathioprine is used at an oral dose of 3 to 5 mg per kilogram per day, followed by the maintenance dose of 1 to 2 mg per kilogram per day. So the next purine antagonist is fludarabine. It is the 5-phosphate of 2-fluoroadenine arabinoside, a purine nucleotide analog. It is useful in the treatment of chronic lymphocytic leukemia, hairy cell leukemia, and indolent non-Hodgkin lymphoma. This fludarabine is a prodrug. Although the exact cytotoxic mechanism is uncertain, the triphosphate is incorporated into both DNA and RNA. This decreases their synthesis in the S phase and affects their function. And this fludarabine is administered intravenously rather than orally because intestinal bacteria split off the sugar to yield the very toxic metabolite fluoroadenine. It is used at a dose of 25 mg per meter square of the body surface area every day for 5 days and every 28 days by intravenous infusion. So under antimetabolites, the next category is pyrimidine antagonist. Examples include 5-fluorouracil. It is a pyrimidine analog, has a stable fluorine atom in place of a hydrogen atom at position 5 of the uracil ring. That is why it got the name as 5-fluorouracil. The fluorine interferes with the conversion of deoxyuridylic acid to thymidyllic acid, thus depriving the cell of thymidine, one of the essential precursors for DNA synthesis. This is how 5-fluorouracil works. The 5-fluorouracil is employed primarily in the treatment of slow-growing solid tumors, for example, colorectal, breast, ovarian, pancreatic, and gastric carcinomas. When applied topically, 5-fluorouracil is also effective for the treatment of superficial basal cell carcinomas. Now the mechanism of action of 5-fluorouracil. This 5-fluorouracil itself is devoid of anti-neoplastic activity. So how this will act? This 5-fluorouracil enters the cell through a carrier-mediated transport system, and this drug, that is 5-fluorouracil, is converted to its corresponding deoxynucleotide, which is the FDUMP, that is 5-fluorodeoxyuridine monophosphate. And this FDUMP will compete with the deoxyuridine monophosphate for thymidylate synthase, thus inhibiting its action. So this 5-fluorouracil itself does not have anti-neoplastic activity. This drug will enter the cell through a carrier-mediated transport system and gets converted to its corresponding deoxynucleotide, which is FDUMP. And this FDUMP competes with the deoxyuridine monophosphate for thymidylate synthase and thereby inhibiting its action. This DTMP or deoxythymidine monophosphate is essential or needed for DNA synthesis as well as cell growth. This DNA synthesis decreases due to lack of thymidine, leading to imbalanced cell growth and thymidine-less death of rapidly dividing cells. And one important point, this leucovorin is administered with a 5-fluorouracil because the reduced folate coenzyme is required in the thymidylate synthase inhibition. For example, a standard regimen for advanced colorectal cancer is irinotecan plus 5-fluorouracil bar leucovorin. This 5-fluorouracil produces the anti-cancer effect in the S phase of the cell cycle. Pharmacokinetics of 5-fluorouracil. Because of severe toxicity to the gastrointestinal tract, this 5-fluorouracil is administered intravenously or, in the case of skin cancer, topically. The drug penetrates well into all tissues including the CNS. 5-fluorouracil is rapidly metabolized in the liver, lung and kidney. it is eventually converted to fluorobeta-alanine, which is removed in the urine. Elevated levels of dihydropyrimidine dehydrogenase can increase the rate of 5-fluorouracil catabolism and decrease its bioavailability. So patients with DPD deficiency, DPD means dihydropyrimidine dehydrogenase deficiency, may experience severe toxicity manifested by pancytopenia. Pancytopenia means low levels of red blood cells, white blood cells and platelets, then mucositis and life-threatening diarrhea. Knowledge of DPD activity in an individual should allow more appropriate dosing of 5-fluorouracil. This drug is infused at a dose of 500 mg per meter square by the intravenous route over a period of 1 to 3 hours weekly for 6 to 8 weeks, or 12 mg per kilogram per day intravenously for 4 days, followed by 6 mg per kilogram intravenously on alternate days for 3 to 6 cycles. So under pyrimidine antagonist, the next drug is capecitabine. It is a fluoropyrimidine carbamate used in the treatment of colorectal and metastatic breast cancer. Capecitabine is well absorbed following oral administration. So after being absorbed, capecitabine, which is itself non-toxic, undergoes a series of enzymatic reactions, the last of which is hydrolysis to 5-fluorouracil. This step is catalyzed by thymidine phosphorylase, an enzyme that is concentrated primarily in tumors. Okay, so this capecitabine undergoes a series of enzymatic reactions and get converted to 5-fluorouracil, and this step is catalyzed by thymidine phosphorylase. Thus, the cytotoxic activity of capecitabine is the same as that of 5-fluorouracil and is tumor specific. The most important enzyme inhibited by 5-fluorouracil and thus the capecitabine is thymidylate synthase. Okay. So under antimetabolites, the last category is cytidine analogs. So under cytidine analogs, the first drug is cytarabine, also known as cytosine arabinosid. It is an analog of 2-deoxycytidine in which the natural ribose residue is replaced by D-arabinose. This cytarabine acts as a pyrimidine antagonist. The major clinical use of cytarabine is in acute non-lymphocytic leukemia. This drug enters the cell by a carrier-mediated process, and like the other purine and pyrimidine antagonists, must be sequentially phosphorylated by deoxycytidine kinase and other nucleotide kinases to the nucleotide form to be cytotoxic. And this nucleotide form is cytosine arabinoside triphosphate. This cytosine arabinoside triphosphate is an effective inhibitor of DNA polymerase. The nucleotide is also incorporated into nuclear DNA and can terminate chain elongation. So it is therefore S-phase and hence cell cycle specific. So the pharmacokinetics, cytarabine is not effective when given orally because of deamination to the non-toxic uracil arabinoside by cytidine deaminase in the intestinal mucosa and liver. Given intravenously, it distributes throughout the body but does not penetrate the CNS in sufficient amounts. Therefore, it may also be injected intrathecally. Cytarabine undergoes extensive oxidative deamination in the body to uracil arabinoside, which is a pharmacologically inactive metabolite. Both cytarabine and uracil arabinoside are excreted in urine. The next drug is azacitidine. It is a pyrimidine nucleoside analog of cytidine. It is used for the treatment of myelodysplastic syndromes and acute myelogenous leukemia. This azacitidine undergoes activation to the nucleotide metabolite azacitidine triphosphate and gets incorporated into RNA to inhibit RNA processing and function. It is S-phase cell cycle specific. Next drug is gemcitabine. It is an analog of the nucleoside deoxycytidine. It is used most commonly for pancreatic cancer and small cell lung cancer. Gemcitabine is a substrate for deoxycytidine kinase which phosphorylates the drug to 2,2-difluorodeoxycytidine triphosphate. Gemcitabine is administered by intravenous infusion. It is deaminated to difluorodeoxyuridine, which is not cytotoxic and is excreted in urine. So we have completed the anti-metabolite anti-cancer agents. So in this slide you can see the complete details of anti-metabolite anti-cancer agents, which includes the folate antagonist, purine antagonist, pyrimidine antagonist, as well as the cytidine analogs and their specific characteristic features. What all are their route of administration, then adverse effects, then notable drug interactions, monitoring parameters, as well as the specific points related to each drug. So you can refer this image or refer this slide for further details. Now the next category of anti-cancer drugs is antibiotics. Okay, so the antibiotics that can be used as anti-cancer drugs includes bleomycin, daunorubicin, doxorubicin, epirubicin, idarubicin, mitoxantrone, actinomycin D, mitomycin C. This actinomycin D is also known as dactinomycin. So what these antibiotics will do? The anti-tumor antibiotics owe their cytotoxic action primarily to their interactions with the DNA, leading to disruption of DNA function. Okay, these antibiotics mainly affect the DNA function. In addition to intercalation, their abilities to inhibit topoisomerases 1 and 2 and produce free radicals also play a major role in their cytotoxic effect. These antibiotics are cell cycle non-specific with bleomycin as an exception. This bleomycin is cell cycle specific, whereas all other antibiotic anti-cancer agents are non-cell cycle specific. So under antibiotics, the first category is anthracycline antibiotics. Examples include doxorubicin, daunorubicin, idarubicin, epirubicin and mitoxantrone. So this doxorubicin is the hydroxylated analog of daunorubicin and idarubicin is the 4-demethoxy analog of daunorubicin. Therapeutic uses for these agents differ despite their structural similarity and apparently similar mechanisms of action. Doxorubicin is one of the most important and widely used anti-cancer drugs. It is used in combination with other agents for the treatment of sarcomas and a variety of carcinomas including breast and lung, as well as for the treatment of acute lymphocytic leukemia and lymphomas. Daunorubicin and idarubicin are used in the treatment of acute leukemias and mitoxantrone is used in prostate cancer. Now let's see the mechanism of action of anthracycline antibiotics. This doxorubicin and other anthracyclines induce cytotoxicity through several different mechanisms. For example, doxorubicin derived free radicals can induce membrane lipid peroxidation, DNA transition and direct oxidation of purine or pyrimidine bases, thiols and amines. So here you can see the diagram that represents the mechanism of action of doxorubicin. This doxorubicin interacts with molecular oxygen producing superoxide ions and a hydrogen peroxide which can cause single strand breaks in DNA. Now the pharmacokinetics. These agents must be administered intravenously. Extravasation is a serious problem that can lead to tissue necrosis. The anthracycline antibiotics bind to plasma proteins as well as to other tissue components where they are widely distributed. They do not penetrate the blood-brain barrier or the testis. These agents undergo extensive hepatic metabolism and dosage adjustments are needed in patients with impaired hepatic function. Biliary excretion is the major route of elimination. So for this anthracycline antibiotics, the major route of elimination is through biliary excretion. So dose adjustments are needed in patients with impaired hepatic function. Because of the dark red color of the anthracycline drugs, the veins may become visible surrounding the site of infusion and red discoloration of urine may occur. Adverse effects. Irreversible dose-dependent cardiotoxicity is the most serious adverse reaction and is more common with the daunorubicin and the doxorubicin. So the specific adverse effect associated with the daunorubicin and doxorubicin is irreversible dose-dependent cardiotoxicity. And this cardiotoxicity apparently results from the generation of free radicals and lipid peroxidation. So this cardiotoxicity occurs due to the generation of free radicals as well as lipid peroxidation. Addition of trastuzumab to protocols with doxorubicin or epirubicin increases congestive heart failure. There has been some success with iron chelator dexamethasone in protecting against the cardiotoxicity of doxorubicin. So the specific toxicity or the specific adverse effect associated with the doxorubicin or daunorubicin is cardiotoxicity, and this can be prevented with the help of the drug dexamethasone, which is an iron chelator. And also, the liposomal encapsulated doxorubicin is reported to be less cardiotoxic than the standard formulation. And the next antibiotic anti-cancer drug is bleomycin. Bleomycin is a mixture of different copper chelating glycopeptides that, like the anthracycline antibiotics, cause scission of DNA by an oxidative process. Bleomycin is cell cycle specific and causes cells to accumulate in the G2 phase. It is primarily used in the treatment of testicular cancers and Hodgkin lymphoma. Then about the mechanism of action, the DNA bleomycin Fe2 plus complex appears to undergo oxidation to bleomycin Fe3 plus. The liberated electrons react with oxygen to form superoxide or hydroxyl radicals, which in turn attack the phosphodiester bonds of DNA, resulting in strand breakage and chromosomal aberrations. So in short, we can say that bleomycin causes breaks in DNA by an oxidative process. Now about the pharmacokinetics of bleomycin. It is administered by a number of routes. The bleomycin inactivating enzyme, it is a hydrolase, is high in a number of tissues, for example liver and spleen, but is low in the lung and absent in the skin, accounting for toxicity in those tissues. Most of the parent drug is excreted unchanged in the urine, necessitating dose adjustment in patients with renal failure. Now coming to the adverse effects, pulmonary toxicity is the most serious adverse effect, progressing from rales, cough and infiltrate to potentially fatal fibrosis. The pulmonary fibrosis that is caused by bleomycin is often referred to as bleomycin lung. Hypertrophic skin changes and hyperpigmentation of the hands are prevalent. Bleomycin is unusual in that myelosuppression is rare. So the specific adverse effect associated with the doxorubicin is cardiotoxicity, and the specific toxicity or specific adverse effect associated with the bleomycin is pulmonary toxicity. Okay, and the pulmonary fibrosis that is caused by bleomycin is often referred to as bleomycin lung. Next drug is dactinomycin, also known as actinomycin D. This dactinomycin is a clear gold colored liquid. It is a chromopeptide antibiotic first discovered for cancer. Most of the chromopeptides contain planar phenoxazone actinosin, which is responsible for the color. Dactinomycin is used for the treatment of solid tumors in children and choriocarcinomas in adults. It is mostly used for the treatment of rhabdomyosarcoma and Wilms tumor in children. Mechanism of action is that dactinomycin binds to double helical DNA and makes a complex. This complexation blocks the transcription of DNA by RNA polymerase. Dactinomycin, a potent anti-cancer agent, exhibits cytotoxicity by inhibiting all rapidly proliferating cancer cells. Dactinomycin is administered by the intravenous route, and it is excreted in urine and bile with a terminal half-life of 36 hours. It does not cross the blood-brain barrier. Then about the adverse effects, dactinomycin causes hematopoietic suppression with a pancytopenia in the first week after completion of therapy. It can cause proctitis. Proctitis means inflammation of the lining of the rectum. Then diarrhea, glossitis. Glossitis means inflammation of the tongue, cheilitis and ulcerations. Due to its action on multiplying cells, dactinomycin causes alopecia. Dactinomycin can cause nausea, anorexia and vomiting within a few hours of administration. Extravasation during intravenous administration can cause severe local injury. In this slide, you can see the summary of anti-tumor antibiotics, and here you can see the specific drugs and their characteristic features. What all are their route of administration, specific adverse effects, is there any notable drug interactions, and what all are the monitoring parameters and the specific notes or specific points related to each and every drugs. Okay, so you can refer this image or refer this slide for further clarification. So we have already discussed about two important categories of anti-cancer drugs, that is antimetabolites as well as antibiotics. So the next category is alkylating agents. Okay, so now we will discuss the drugs that comes under alkylating agents. First one is nitrogen mustards. Examples of drugs that comes under this category is meclorethamine, cyclophosphamide, ifosfamide, chlorambucil, melphalan, bendamustine, ethylenimines, ultratamine and thiotepa. Then alkyl sulfonates, busulfan, nitrosurase such as carmustine, lomustine, streptozotocin, then tricine such as decarbazine and temozolomide, then methyl hydrolysine, example is procarbazine. So these alkylating agents exert their cytotoxic effects by covalently binding to nucleophilic groups on various cell constituents. Alkylation of DNA is probably the crucial cytotoxic reaction that is lethal to the tumor cells. Alkylating agents do not discriminate between cycling and resting cells, even though they are most toxic for rapidly dividing cells. They are used in combination with other agents to treat a wide variety of lymphatic and solid cancers. In addition to being cytotoxic, all are mutagenic and carcinogenic and can lead to secondary malignancies such as acute leukemia. So first we will see about cyclophosphamide and ifosfamide, both comes under nitrogen mustards. They are cytotoxic only after generation of their alkylating species, which are produced through hydroxylation by cytochrome P450. Okay, so the cyclophosphamide as well as ifosfamide, they act as cytotoxic only after generation of their alkylating species. How these alkylating species are generated? By hydroxylation with the help of cytochrome P450 enzyme. These drugs have a broad clinical spectrum and are used as single agents or in combination in the treatment of a wide variety of neoplastic diseases such as non-Hodgkin lymphoma, sarcoma, and breast cancer. Then regarding the mechanism of action, cyclophosphamide is the most commonly used alkylating agent. Both cyclophosphamide and ifosfamide are first biotransformed to hydroxylated intermediates primarily in the liver by the cytochrome P450 enzyme system. The hydroxylated intermediates then undergo metabolism to form the active compounds phosphoramide mustard and acrolein. This is very important. That is the active metabolites or the active compounds produced as a result of metabolism of the cyclophosphamide is phosphoramide mustard and acrolein. The reaction of the phosphoramide mustard with the DNA is considered to be the cytotoxic step. Then about the pharmacokinetics, cyclophosphamide is available in oral and IV preparations, whereas ifosfamide is only IV only. Okay, so the difference is that cyclophosphamide is available in both oral and intravenous preparations, whereas ifosfamide can be given only through the intravenous route. And the cyclophosphamide is metabolized in the liver to active and inactive metabolites, and minimal amounts are excreted in the urine as unchanged drug. Ifosfamide is metabolized primarily by the CYP3A4 and 2B6 isoenzymes. It is mainly renally excreted. Then adverse effects. A unique toxicity of both the drugs is hemorrhagic cystitis. Okay, so the specific toxicity associated with the cyclophosphamide and ifosfamide is hemorrhagic cystitis, which can lead to fibrosis of the bladder. Bladder toxicity has been attributed to acrolein in the urine in the case of cyclophosphamide and to toxic metabolites of ifosfamide. As we have already discussed in the previous slide, that is the active compounds as a result produced as a result of metabolism of cyclophosphamide is phosphoramide mustard as well as acrolein. And this acrolein is responsible for the bladder toxicity caused by cyclophosphamide. So in order to prevent this bladder toxicity or hemorrhagic cystitis, what we can do? Adequate hydration as well as IV injection of mesna. Okay, mesna is known as sodium 2 mercaptoethane sulfonate. It will neutralize the toxic metabolites and can minimize this problem. So this cyclophosphamide is given along with this mesna. So the purpose of mesna is to prevent the hemorrhagic cystitis or prevent the bladder toxicity caused by cyclophosphamide. Neurotoxicity has been reported in patients on high dose ifosfamide, probably due to the metabolite chloroacetaldehyde. So under alkylating agent, next category is nitrosurease. Carmustine and lomustine are closely related nitrosurease. Because of their ability to penetrate the CNS, the nitrosurease are primarily employed in the treatment of brain tumors. This is an important point. Nitrosurease have the capability to penetrate the central nervous system. So these drugs are primarily used in the treatment of brain tumors. Then the mechanism of action. The nitrosurease exert cytotoxic effects by an alkylation that inhibits replication and eventually RNA and protein synthesis. Although they alkylate DNA in resting cells, cytotoxicity is expressed primarily in cells that are actively dividing. Therefore, non-dividing cells can escape death if DNA repair occurs. Nitrosurease also inhibit several key enzymatic processes by carbamylation of amino acids in proteins in the targeted cells. Then pharmacokinetics. Carmustine is administered intravenously and as chemotherapy wafer implants, whereas lomustine is given orally. Because of their lipophilicity, these agents distribute widely in the body and readily penetrate the CNS. The drugs undergo extensive metabolism. Lomustine is metabolized to active products. The kidney is the major excretory route for the nitrosurease. So the next drug is streptozotocin. It is an antibiotic brought under this group due to its structure containing methyl nitrosourea group attached to the glucose. Because of this specific structure, this drug comes under this particular group. Then it is used for the treatment of pancreatic cancer and malignant carcinoid tumors. Mechanism of action. Due to its glucose structure, it has higher affinity for pancreas, and in experimental animals it causes diabetes by the destruction of islets of Langerhans. Then pharmacokinetics, it shows a very short half-life after intravenous administration of 15 minutes. Only a fraction of drug, that is 20%, is excreted in urine in the unmetabolized form. Adverse effects include nausea, vomiting, elevation of hepatic enzymes and renal toxicity are reported. This streptozotocin should not be combined with other nephrotoxic agents. It is also reported to cause hematological toxicity in some patients. Next one is procarbazine. It comes under methyl hydrazines. It is used for the treatment of Hodgkin's disease and malignant brain tumors. This MOPP is a chemotherapy regimen consisting of meclorethamine, vincristine, procarbazine and prednisone. Mechanism of action is that upon administration, procarbazine is converted by cytochromes of the liver into a highly reactive alkylating species which in turn methylates DNA. It is extensively metabolized and excreted. Adverse effects include leukopenia and thrombocytopenia. Then these gastrointestinal side effects are very common. Then this procarbazine is a weak monoamine oxidase inhibitor and blocks the metabolism of catecholamines. Okay, so this is also important. Procarbazine is a weak MAVO inhibitor. So it blocks the metabolism of catecholamines. It is highly carcinogenic, mutagenic and teratogenic and is associated with the risk of developing acute leukemia in patients undergoing treatment with this agent. So the next drugs are dacarbazine and temozolomide. Both comes under triazines. Dacarbazine undergo biotransformation or metabolism to an active metabolite. So the name of active metabolite of dacarbazine is methyl triazinoimidazole carboxamide. Okay, so this metabolite is responsible for the alkylating activity of this agent by forming methyl carbonium ions that attack the nucleophilic groups in the DNA molecule. The cytotoxic action has been attributed to the ability of its metabolite to methylate DNA on the O6 position of guanine. It is used in the treatment of melanoma and Hodgkin lymphoma. This temozolomide is also related to dacarbazine because both must undergo biotransformation to an active metabolite MTIC. Okay, MTIC I have already discussed in the previous slide. Temozolomide does not require the cytochrome B450 system for metabolic transformation and it undergoes chemical transformation at a normal physiological pH. Temozolomide also inhibits the repair enzyme O6-guanine DNA alkyl transferase. Temozolomide differs from dacarbazine in that it crosses the blood-brain barrier and therefore it is used in the treatment of brain tumors such as glioblastomas and astrocytomas. Okay, so the difference between this dacarbazine and temozolomide is that temozolomide can cross the blood-brain barrier and it is useful in the treatment of brain tumors. It is also used in metastatic melanoma. Temozolomide is administered intravenously or orally and has excellent bioavailability after oral administration. The parent drug and metabolites are excreted in urine. Other alkylating agents. So the first one is meclorethamine. It was developed as a vesicant. It is a nitrogen mustard during the World War I. Its ability to cause lymphocytopenia led to its use in lymphatic cancers. Then melphalan, it is a phenylalanine derivative of nitrogen mustard. It is used in the treatment of multiple myeloma. This is a bifunctional alkylating agent that can be given orally, although the plasma concentration differs from patient to patient due to variation in intestinal absorption and metabolism. The dose of melphalan is carefully adjusted by monitoring the platelet and white blood cell counts. Chlorampicillin is another bifunctional alkylating agent that is used in the treatment of chronic lymphocytic leukemia. Then busulfan, it is an oral agent that is effective against chronic granulocytic leukemia. This agent can cause pulmonary fibrosis or it is often referred to as busulfan lung. Like other alkylating agents, all of these agents are leukemogenic. Bendamustine is administered through the intravenous route over a period of 30 minutes. It is approved for the treatment of chronic lymphoid leukemia and non-Hodgkin's lymphoma. So in this slide, you can see the summary of alkylating agents. That's the key points to be remembered about these drugs. So far we have discussed about three important categories of anti-cancer drugs. So the first one is antimetabolites, second one is antibiotics, and the third one is alkylating agents. And the remaining classification or the remaining categories of drugs we will discuss in the next session. Hope you all have liked this video. Please like, share and subscribe. Thank you everyone. Thank you for watching this video. Have a good day.